evening, everyone. Welcome to the Lung Cancer Living Room. It's so amazing to see so many beautiful faces in the room tonight, especially those that I mostly only get to see online or over email. Welcome, welcome, welcome. For those of you watching online, thank you for joining us. And for those of you who may not know who I am, my name is Danielle Hicks, and my role here at the Foundation is anything and everything that has to do with patient touch. So any of our patient programs, outreach, education, support services is my area of responsibility. I'm so grateful to see all of you in the room tonight. We wait for this meeting every year, Best of ASCO, right? Everybody wants to know what's coming down the pipeline, what the data is showing, what some of our potential next options are for lung cancer patients around the world. So we're very, very pleased to have Dr. Jonathan Riess here from UC Davis Comprehensive Medical Center to talk to us about what happened at ASCO and what we can expect coming down. So thank you for coming, Jonathan.
Great, privilege to be here. Thanks for having me.
Super, super excited to have you here. Some of you, in front of you, I just want to point this out. Janet Freeman Daly, who I think a lot of you know and who I think is signed in tonight, went to ASCO and gave her sort of patient perspective and insights on what she learned while she was there. And then she was oh so kind as to write up this amazing report on some of the things that she found while she was there. So please, if there's not enough copies on the table, we've got some in the back for you to take home with you. And if anybody online wants a copy, Janet will be blogging about it, and we will also be posting it. So I just want to make sure that everyone knows that that's there, and to give a huge shout out and thank you to Janet for putting it together. We're going to start the meeting tonight the same way we do every night, with an around the room, especially because I'm excited about some of the new faces that are live and in person tonight. Tell us who you are, where you're from if you're not from here and you're new, when you were diagnosed, what you were diagnosed with, and how you're doing. And then once we get around the room, we'll get to our meeting. So I don't know if Sam is done. I always start kind of.
Who are you? Who are you?
I'm Samantha. Oh, sorry.
My name is Samantha Mixon. I was diagnosed Thanksgiving 2012 with stage 4 non-small cell lung cancer. I've been on Tarceva ever since, and now I'm stable. I have 2 tumors that aren't active, but other than that, I'm doing pretty well. I have a daughter, she's 12, and a stepdaughter, who's 13. And then another one that just moved in my house that's 18. And so, yeah.
And where are you from?
I'm from Atlanta originally. Now I live in St. Simons, Georgia, which is about an hour north of Jacksonville. People that don't.
Nice. Thanks, Sam.
Introducing. Sorry, came in late. I'm Ina Bauman, and I had surgery and a lobe removed 2.5 years ago. And I'm doing really well. I'm very, very, very grateful. And I love this organization, and I decided to get more involved just quite recently. And I live in Los Altos.
We're happy to have you.
My name's Dave, and I live in Belmont. I was diagnosed in March of this year with stage 4 EGFR, so I take Tarceva and have the rash to prove it. This is I think my 4th time. I was lucky enough to meet Michelle, I think 3 days after my diagnosis, so I've been involved ever since.
Hello, I'm Kurt Schindler. My wife, Susan Palmer, was diagnosed at the beginning of May. She is arriving any moment now. So I'll pass it on.
My name is Fred Palmer, and I live in Belmont, which is one town north of here. I was diagnosed with non-small cell lung cancer in October of 2013, and I'm currently on immunotherapy.
Hi, my name's Betty Corner. I was diagnosed in September 2014 with oligometastatic stage 4 lung cancer. I had surgery in January of 2015, and am EGFR positive and taking Tarceva still. I've since had a craniotomy where they were looking to see what one of my cyber-knifed Mets might be doing, and they missed it. It was too little. But since then, my MRIs have been good, so I'm doing well. Thanks.
Thanks, Betty.
I'm Rick, and my wife Tina is here, and I'll let her talk.
My name is Tina. I was diagnosed in 2010, and I did chemo and radiation initially, and then went on Tarceva for maintenance 6 years ago, and I've been on Tarceva since with clean scans, NED. I recently signed up for a liquid biopsy clinical study, whatever, research study. And so I'm kind of excited about that, and I will get my results of my blood work in August next month.
Hi, I'm Sally, and I feel funny repeating my story every month for 8 years.
That's great.
Anyway, I entered an early detection study, the International Early Lung Cancer Assessment Program, and was watched for 5 years, and then one of the nodules grew, but because I was in this study, excuse me, it was my nodule that had grown was found early, and I had my lower right lobe removed, and I have other nodules that they're still watching, but knock on wood, nothing's been big enough to do anything about, so I'm very lucky.
Thanks, Sally.
I am Ron. I'm speaking for my wife, Joan. Joan was diagnosed in October of 2013 with non-small cell lung cancer, EGFR positive. We are now 45 months into the journey with 15 different lines of treatment so far. And so we wanted to be here because we were coming back from the hospital, and they said, Waze told us it was cheaper or faster to come here and steal free food than to go home and cook. So we're here, and we're delighted. Dr. Riess is here. We did a couple clinical trials with him and Dr. Gandara, and it's good. And Joan wants to say hi, because this is probably the last one she's going to attend, she says.
My name is Gail, and this is my first time here in person, but I've been watching the live stream for the last 4+ years from Los Angeles. I was diagnosed in April of 2013 with stage 4 non-small cell. I received carboplatin and Alimta, and then Tarceva, and it's almost 4 years on Tarceva.
And where did you just come from? Sorry.
She said LA.
No.
Crater Lake.
Crater Lake.
Oh, great. Where?
She was up in, she went from LA up to Oregon and stopped here on her way home.
Oh, good girl.
Yeah.
Good evening, everyone. My name is Don Stranathan, and I have no excuses. I only live in Santa Rosa, but this is the first time I've made it down. Every time I've come before, Bonnie is always traveling, so I never get here. So. But I was diagnosed with stage 4 non-small cell lung cancer in June of 2009. I did a year of chemotherapy and radiation, and then was on Tarceva for 6 years. Had progression in 2015 and found out I never even had the EGFR mutation. I just got lucky. And after a second opinion and genomic sequencing that Bonnie helped me with, finding the facility, I found out my next best option would be immunotherapy, and I just had my 37th infusion of immunotherapy last week and still have stable disease again. So I wanted to give a shout out to my friend Sue Lee, who's watching. She was going to fly in from Utah, but she had to start a new treatment last week, but she wanted to say hi to everyone. So.
Okay. Is she watching?
Yes.
Okay. Yay.
Over here. Pick a camera.
Hello to Utah.
We're going to go here, and then we'll go around the room.
Okay, well, let's go back there and then we'll go over there. And,
I think she wants to catch the camera. Here, yeah,
okay.
there we go.
Okay. Okay.
We're coming here.
Over here. We'll come around here.
Yeah.
Camera's over here.
Hi, I'm Jill DeSimone. I head up Merck Oncology and am honored to be with all of you this evening. And we have several folks here from Merck, and thank you for all of your courage.
And I'm Maria Sheldon, is also with Merck Oncology, and thank you again for letting us attend this meeting and live in the Bay Area along with my colleagues.
Hi, I'm Angela, and I'm also with Merck. Jill and Maria and Abby down here, and we are just really happy to be here with you tonight. Thanks for letting us join you.
You're going to take it in the back, and then we'll come around.
Arash first.
You don't have to, no.
I'm Zita Taylor with Bristol Myers Squibb Oncology, and glad to be here and listen to the educational program.
Hello, my name is Christine Meacham, and I'm with a company called Oncocyte. We're working on a diagnostic, a liquid biopsy diagnostic, which would be pre-cancer diagnosis to try to reduce some of the people that go through the experience of having a biopsy unnecessarily. So I'm very honored to be here. Thank you for letting me come, and thank you for sharing your stories.
I'm Joanne Berridge from Belmont. I was diagnosed with stage 4 adenocarcinoma in September of 2016. It is EGFR. I've been on Tarceva for 10 months now and have been in remission until now. I'm one of those cases that went a whole year undiagnosed. I say that every time just to emphasize to whatever clinicians might be listening that it wasn't a cough, it wasn't allergies, it wasn't postnasal drip, and it wasn't acid reflux. It was lung cancer. But so far, so good, and hope is the big thing. And I love hearing the stories of like Tina and Sally, who've been 8 years, 10 years, 11 years out. That's wonderful. And I have with me today my sister Marion, who's visiting from Mexico, and as usual, my husband Ron. And I'll give a shout out to Jackie McNamara.
Okay. Jackie's always on.
And then Linda has to introduce herself. She made a surprise visit.
Hi, my name is Linda. I'm from San Diego. This is important to come to these meetings. I wish I could come every month. I try to, but it's a long drive, but it's worth coming to. So all of you that have just joined, you're in the very best possible place. Our daughter was diagnosed with stage 4 lung cancer in September of 2009, and she's doing great. She's been taking daily chemo pills. She takes them at night. She teaches elementary school all day, and she's a single mother with a 10-year-old little boy. So she's doing it all. I call her Wonder Woman. And the pill is working for her. So we'll just keep marching forward, and that's what Wonder Woman would want. Anyway, you're in a great place. These are great people.
Thanks, Linda. I think, Susan, I don't know if you guys want to say anything. I know she came in late. Do you want to introduce?
Susan, do you want to say hi?
There's a mic right there.
Hi, I'm Susan Palmer, and I was diagnosed in early May with the KRAS mutation. Negative to immunotherapy and also markers, but chemo's working. So I'm just going to go with that. And it's good.
Very good. I think everybody's done.
Yeah.
Thank you all for sharing your stories. I think it's so important, for a couple of reasons. A, that especially for some of the new people, you know who kind of you're looking at around the room, and then especially for Dr. Riess to kind of know who his audience is, at least, at some sort of a high level. So thank you all for sharing. I don't know if anybody online wants to. Nobody has anything to say? Okay. So one of the things I do want to tell everyone throughout, especially if you're new, this is Q&A throughout, so we want it to be interactive. So as we're having discussions, if you guys have a question, please raise your hand and we will call on you in the order that I see you, which might not necessarily mean it's the order you raised your hand, but it's in the order that I see you. So I promise that I will get to you. And don't be shy about asking questions that are personal to you, because that's what this is about. This is about, putting this program together to kind of help, to completely help you guys understand the process and to be able to better navigate not only what your current therapy is, but what your options might be in the future. So everybody keep that in mind. And with that, welcome again.
It's great to be here.
Thanks for coming.
Thanks
for coming. So before we jump into Best of ASCO, what is ASCO? What is ASCO and what does it mean and why is it so important?
So ASCO stands for the American Society of Clinical Oncology. So I would say the majority, if not all, of clinical oncologists in the United States and many across the world are members of this oncology society, and we meet every year for our major annual meeting where often many of the biggest advances in how we treat cancer, not just lung cancer, but basically every cancer, is presented. There's other meetings that are more specific to different tumor types like lung cancer and prostate cancer and colon cancer across the country over different parts of the year. But at this annual meeting, the majority of folks who practice clinical cancer care meet, and it's doctors, nurses, caregivers, it's people from the pharmaceutical industry and medical device industry. It's probably one of the largest meetings of its kind, and we all meet in Chicago because I don't think there's another conference center that can accommodate all the people in the country. So I think it's booked for Chicago for like the next decade. And I think there's over 40,000 people on average at the meeting. So it's a huge meeting. It's actually, when you first go there, it's kind of a bit overwhelming with all the people and the center. You can get a lot of exercise in too, walking back and forth across the conference center. It's a huge complex, but there's some great research presented, and it's a good way to meet with friends and colleagues and discuss research collaborations and see what's new in the field of any cancer. But for myself, who mainly focuses on lung cancer, what's new and cutting edge in lung cancer clinical research and how best to advance care for our patients.
I would just like to add one thing about this year and the end of last year. More drugs have been approved for lung cancer in the last 18 months than in the last 4 decades. So I think you would agree this is probably the most hopeful time ever for lung cancer.
It's been incredibly exciting at the pace we've been able to get new drugs to patients. It's really been remarkable. It's not good enough, but at least things are moving in the right direction. And I think especially with targeted therapies and immunotherapies, we've really just had incredible, substantial advances, like I said, over the 18 months to, every month there's something new.
Right.
So it's been very exciting. And some of these ones that are new, like I think we'll talk about one, this Luxo 101 drug, it may be 0.5% of lung cancer, 1%, 2%, but you add it up and it turns out to be a lot of folks that we're able to really bring treatments to, and it just kind of speaks to how we're trying to personalize the treatment of cancer for a lot of patients, and that's been probably one of the most exciting things. I mean, I could think to when I was a fellow, I guess I finished about 4 or 5 years ago, not that. From what was then to now, it's just been, even in that short period of time, it's just been remarkable. But we're not there yet, so we still have more and more to do, but at least there's steps in the right direction, and those steps are getting faster and faster, which is nice.
I thought I heard you take a breath like you were going to say something.
No, just breathing.
So before we jump into some of the new stuff, you had mentioned about your focus on lung cancer, which I know you have. What made you choose lung cancer as sort of a focus?
So that's a really good question. I wasn't sure what I wanted to do when I was in medical school. I always was interested in cancer and taking care of cancer patients. Actually, I decided to go to medical school because actually I was initially going to be a history professor, but I didn't do very well writing history papers. So my Jewish grandmother.
So you decided to be a doctor.
My Jewish grandmother said, "Oh, you should go be a doctor." I was down in Florida in like Delray Beach, and she gave me this suggestion. And so I met with I don't know if you call college people guidance counselors, and I thought it was like you would go to kind of community, like if I go to community college medical school, I'll be fine. So I met with them, and they're like, it doesn't work that way.
Are you crazy?
And so this guidance counselor, I don't know, advisor or whatnot, said, I'm like, what do I do? Do I need to get into med school? But she just said, get A's. Okay, so it took a little extra time, but I went to medical school, and I was interested in taking care of cancer. My stepfather was diagnosed with leukemia, and unfortunately he passed away. And then when I was a resident, my mother, shortly after he passed away, wound up in the emergency department. They found a lung mass on chest x-ray. And so she was diagnosed with lung cancer. It's been, I think, over 6 or 7 years now. She had a surgery, and unfortunately, every year it's stressful, but the CTs come back and look good. Yeah. So that's what got me more interested in lung cancer. And then I came out here to UCSF for residency, and I kind of got more interested in that, working. We have great lung cancer doctors in this area of Northern California at multiple different places. And so I was at UCSF and Stanford at UC Davis, and there's just remarkable doctors, both in their research and how they take care of patients, and that's kind of what spurred me to pursue a career in lung cancer. So I'm here now. So,
Dr. Riess, not to add any pressure, but your mom is online.
Well, what Jewish mother wouldn't be?
That's funny. Hi, Mom.
That's awesome. I'm glad I asked that question because you mentioned it, and I thought I had to ask the question because I've never asked you. So
that's awesome.
That's fantastic.
Yeah.
And we're all very glad you decided to take this leap instead of be a history professor.
Probably have a lot of proud moms in the room too. So we get it.
Yeah. So with that, I think we're going to start in sort of the immunotherapy space because that's been the hot topic for the last few years, and maybe talk about where not just sort of where we started, but where we're headed, and then maybe just for those who might know or might not know, what is immunotherapy?
So I think immunotherapy, at its, I guess, basic is just trying to harness the immune response to best fight the cancer. And there are a lot of ways that the body has adapted to recognize things in your body as foreign and try to get rid of it. It helps, but aside from cancer, it's mainly to things like autoimmune diseases and so forth, this kind of, fighting infections and so forth.
Keeping pregnancies.
And, basically everything. But, cancers can find ways to outwit the immune response so it doesn't recognize it as foreign. And we've I think for many years, going back decades, there's been always this thought, well, if we could juice up the immune system to attack the cancer, we can make substantial advances. And there's been, for decades, all this research, and just now over the past several years has it really substantially, impacted lung cancer. And I think the biggest advances have been with these checkpoint inhibitors, where these lung cancer cells can express these proteins that tell the immune system to go away. And these antibodies can block that interaction, allowing the immune cells to attack the cancer. And there's been, several drugs that have been approved by the FDA, these PD-1 and PD-L1 antibodies that do a very good job of that in some patients. So, overall, if you take all patients, about 20% or so of these PD-1 antibodies, it shrinks things really well and keeps things in check for some time. But we're still learning more about why it works in certain patients and why it doesn't work in other patients. And that's been, I think, a focus of ongoing research to try to make it work better for everybody. And that's where kind of there's a lot of combination trials that are looking at, because these initial antibodies have been so successful in a group of patients. There's a lot of different clinical trials doing combination treatments to try and do better. So that's where we are in terms of kind of an overview of immunotherapy for lung cancer. I think specifically at the ASCO meeting, there were some abstracts presented that were noteworthy. I think one was this one with looking at long-term outcomes of pembrolizumab and in first-line treatment of non-small cell lung cancer. So there was this trial called KEYNOTE-24 that randomized patients to either get the standard, which was chemotherapy with the platinum drug, versus this pembrolizumab, one of these checkpoint inhibitor drugs, PD-1 antibodies, in patients who had the highest expression of this protein called PD-L1, so 50% or more. And these PD-1 antibodies, bind to PD-L1 and kind of release the brakes of the immune system not attacking the cancer as well. And so this showed that the pembrolizumab drug, patients lived longer, and it was longer till the cancer grew and more tumor shrinkage. And so they looked at long-term outcomes because they had longer follow-up, and it still looked good. And they looked at subsequent treatment and showed that subsequent treatment, even after the initial pembrolizumab, for example, with chemotherapy, looked better than vice versa, than the chemotherapy first and subsequent treatment. And there was some thought that, maybe there's some changes in the cancer microenvironment that makes subsequent treatments better after the pembrolizumab, but that's still kind of not fully proven. So I would just caution people about that. But I think it just emphasized that for patients whose lung cancers have this high PD-L1 expression, it just reiterated that the pembrolizumab is better than standard kind of the platinum doublet chemotherapy that we've given for a number of years. And I think I would just highlight, because a lot of patients have been asking about it, is, now based on a smaller trial, a phase 2 trial, it's actually been FDA approved with the smaller trial, which is a bit unusual, of chemotherapy in non-small cell lung cancer that's not squamous lung cancer, like adenocarcinoma, that giving chemotherapy with carboplatin and pemetrexed with the pembrolizumab and seemed to have a higher response rate than the chemotherapy alone. So actually, if for any level of PD-L1 expression, that's positive, 1% or more, that's actually FDA approved now, although it's based on a smaller trial, and I think we need more information to really see is there an overall survival benefit to patients actually live longer. But that also looks promising as well, for even if PD-L1 expression isn't above the 50%. So that was one of the abstracts presented, and then that was in kind of the big oral session that kind of highlights the most prominent abstracts for lung cancer. I think another one that was presented kind of goes to the length of time that we treat patients on these immunotherapy drugs. And this was presented by my colleague, Dr. Gandera at UC Davis, that looked at atezolizumab, which is another one of this is a PD-L1 antibody. You've probably seen all the commercials for these on the NFL if you watch NFL. But the atezolizumab studied after the platinum chemotherapy didn't work. Patients were randomized to receive atezolizumab versus a standard chemo called docetaxel. And it showed that the atezolizumab patients lived longer and longer for the cancer to go back. And the patients that basically the patients that continued the atezolizumab beyond the standard of what we call progression, there was a subset of patients that still benefited. And I think that brings up the question that a lot of doctors who treat lung cancer, grapple with is a patient is on these drugs for a while or some time, and they see that the cancer is growing. When is it time to switch gears and try something new, and when is it time not to? And that's been, we like to be optimists. So when do you make that call if things are growing a little bit? If not, so I think the key takeaway for me is you really just need to individualize to the patient, because sometimes we invoke this kind of pseudo progression where we say, oh, well, maybe it's infiltration of these immune cells and things look a little bit better. But it's always hard to differentiate. It can be hard to differentiate sometimes. For me, what I do is if things look a bit bigger and I'm thinking about changing things, I see, well, how do you feel? So usually the patients where I've seen it, where they've still benefited after it looks like the cancer's growing, it's been people that feel really good. It's like, oh, things are growing a bit, but hey, I feel great. I feel better. Well, that's one sign. And also just the amount of growth. Is it a little bit, or does it seem more substantial than that? Because these are the kinds of factors that we take into account to kind of individualize patient care about when to switch treatment on these drugs and when not to.
And for clarification, when you were talking about pseudo, that really means it could be inflammation rather than the tumor growing.
Exactly.
But I have a question here, and if it's the same in immunotherapy as it is in targeted therapies, for example, do the IOs tend to work the same in that sometimes you get like a small progression here there, you can spot treat it, but it's still working everywhere else, and that's sort of the idea. So you kind of follow it and do it the same way, like oligo.
So that's a great question. So bringing up the idea of what do you do with the term, I guess, is oligometastatic disease. So what do you do in situations where it looks like things are stable for some time and then there's a new spot or two? So the short answer is it depends. The long answer is if somebody's doing well and there's one new spot, if people are feeling great, sometimes we watch it if it's small. Other times you could consider doing some focused treatment, such as radiation, and continuing the treatment. And we've taken this concept. This first came from what we do with targeted therapies. So the thought is, for example, in EGFR mutant lung cancer, somebody is on Tarceva for a while, and there's a new spot, but everything else looks really good. Then focusing treatment on that with radiation and continuing treatment, we've looked at things and we've seen that you could get some additional benefit by giving the focused radiation. And because we think that things may have changed in that part of the cancer, that you're then able, that may not be present in other places, these resistance mutations that you could hit and then continue the same drug to try to maximize each line of treatment that you're on.
I have a question. How long has it been since you guys have started doing like the targeted radiation? For instance, as like, okay, it'll be okay to do that.
How long, in terms of how long that's been kind of a common practice?
Right.
I mean, since I have been practicing, I've been maybe 5 since a fellowship, maybe 7 years, and we've been using these targeted therapy drugs, generally we have been doing that. So definitely over the last several years.
Because back in 2013, I've been on Tarceva since 2012. I started having progression, and what they did is went in and radiated the one tumor.
Yep.
But my insurance company said it wasn't medically necessary.
Yeah.
So
Well, oftentimes we have to grapple with those types of issues and fight.
Okay, I was just seeing if it was standard or not, because I was thinking, am I the only person that this has happened to? Okay.
It's generally considered standard, but sometimes the people that review the insurance stuff need to be educated on that. That's the way I put it.
Totally agree.
Yeah.
We had a patient. She might be online tonight. She had fiducial markers placed, approved, and then her insurance company wouldn't approve the actual radiation. So you're like, wait a minute, right? So there are a lot of those things that happen. Don, I think you had a question.
I did. Dr. Riess, was there any discussion at ASCO about early stage lung cancer, stage 1 and 2, before surgery, administering 1 or 2 infusion of immunotherapy. I heard there was trials going on that it would kill like 90% of the cancer before it was even removed. And then the second part of the question, I have a number of friends online that when I started immunotherapy a year and a half ago, the protocol was until progression or it became toxic. Now I'm having people where their oncologists are telling them they're going to keep them on it for 2 years to 5 years. Is there any set protocol as far as how long a person will stay on immunotherapy, or is that being driven by the insurance companies?
So those are great questions. So your first question was asking, well, what about moving up immunotherapy to early stage? And there are ongoing clinical trials looking at that. So there's been what we call, the term is window of opportunity studies, where they're giving immunotherapy before surgery. This is, a lot of studies have been done like this, not with immunotherapy, but in breast cancer, looking at treatments before taking people to surgery. So this is giving immunotherapy before surgery, and then a lot of these studies, you do the surgery and you look at the changes in the tumor immune microenvironment, before and after, to see if you can see any signal of benefit, and also how many patients respond. And it looks promising. And then there's other, we're having trials for adjuvant treatment too. So after surgery, we're having large trials looking at, does adding immunotherapy have benefit versus not doing immunotherapy? And those are still in progress. So we don't have all the answers yet, but I think it looks very promising. And you would think that potentially more early stage lung cancers, there's more kind of immune surveillance going on versus metastatic lung cancers, where this approach may have particular promise in earlier stage lung cancers. So you'll have more of an answer in the next year or two, but overall it does look promising, and there's multiple clinical trials that are looking at this. So hopefully we'll have some answers pretty soon.
This is one of the things that just keeps resonating in my head and it's every time at this meeting. Well, it's always, but a lot at this meeting when we're talking about best of ASCO and the data and all these clinical trials, is the importance of participating in clinical trials. And we talk about it all the time. We cannot make advancements fast enough if only 3 to 4% of the adult cancer population is participating, right? And there's so much benefit to be had in this space. And that's a whole other living room, but it just keeps like ding, 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 ding in my head the whole time we're talking.
But on that note, and Danielle, you're absolutely right. But we are working, our foundation is working really closely with now 4 pharmaceutical companies on redesigning patient consent forms, protocols, all of the other things. And there's a huge access issue. We have pharma in the room tonight, and I'm sure some that are dialed in. If 50% of all the clinical trials in the United States happen in 10 states, we have an access problem. So to Danielle's point, clinical trials are absolutely necessary, and at times where the patient gets the absolute best drug for them, other than what's on the market, but they can't get to them. So we have to work. Shout out to pharma to change that.
Boom. Does anybody else have any questions? Andrea?
Yeah, so I have a couple patients online. One newly diagnosed, just diagnosed 6 weeks ago. Currently, she's ROS1 positive, currently on Xalkori. Will she ever be eligible for immunotherapy?
So that's a great question. So Xalkori, also known as crizotinib, is approved for the treatment of ROS1 advanced lung cancer. And ROS1 fusions are special changes that drive the lung cancer growth. And there's a great drug called crizotinib, also called Xalkori, that is extremely effective in terms of shrinking these types of lung cancers with, I think the average time to things starting to grow again is about 20 months. So for advanced lung cancer, that's almost as good as it gets. In terms of immunotherapy afterwards, that's certainly one of the treatment options. We're, as I mentioned before, we're learning more about immunotherapy and why it works in some patients and why it doesn't work in others. And patients, ROS1 lung cancers like EGFR and ALK are typically more associated with having these mutations and these changes and not with smoking. And we're learning more about this, but we're getting a signal that in lung cancers that aren't associated with smoking, on average, the benefit may be a bit less than with smoking-associated lung cancers. And so, for example, at UC Davis in EGFR mutant lung cancer, where we're combining afatinib, which is an EGFR drug, with pembrolizumab to see if we could see changes adding an EGFR drug to the immune microenvironment that may make these drugs work better. So those are the types of things we're looking at. So certainly immunotherapy could be one component of the next step of treatment. I hope that's not for a very, very long time. She's on the right treatment. But I think looking at PD-L1 expression and other things, and potentially trials or chemotherapy even before immunotherapy in this situation may be something to look at, because a drug called pemetrexed and with platinum can often be effective as the next steps as well. But I would also mention, in addition to immunotherapy, there's new pill drugs for ROS1 lung cancer. So there's a drug called lorlatinib that's being studied, and there's others too, but lorlatinib is one of them as kind of a next generation type drug. It affects ALK and ROS1, as does crizotinib and some of the other drugs. But I would urge her to look for things like, look for drugs like that as well, lorlatinib, which is a next generation kind of ALK and ROS1 inhibitor. So those pill drugs look particularly effective. I know Bonnie could speak that the Adaria Foundation is looking at this ROS1 initiative to try to improve treatments for ROS1 lung cancer, these rare types of tumors. So I don't know if you want to speak to this patient about that too, to get them involved.
Well, you're absolutely spot on. You said everything there is to say. But they're exciting times, really exciting times, especially with the combination therapies, that really weren't even happening a year, 18 months ago.
One of the things I do want to say, if this is a new ROS1 patient that hasn't contacted us, to contact us, because we can put them together with all the other ROS1ers.
Yeah, absolutely.
Yeah, and make sure that they're involved in what's happening. It's done?
Yeah.
Perfect.
Okay.
All right, see how fast we are?
Look at you.
There is another question online. Can a patient diagnosed stage 4, both lungs only, ever be eligible for radiation?
That's a good question. I think it depends on the specifics. I think there are certain situations where radiation could be useful, and there's other situations, depending on how much of both lungs is involved, where radiation may not make sense. So I think it's hard to answer the question without knowing kind of more specifics. But if they wish, I'd be happy to get in touch with them offline to help with that.
Jonathan, one of the reasons you're getting so many questions about this is that not every patient is able to receive academic type care. Multidisciplinary, genomic profiling, all of those things. So what advice can you give patients online and in the room that don't have access to academic care and don't have access to one of our lung cancer centers of excellence? What do they do? I think that's the reason we're getting so many questions about these things. Where do they go? What do they do? How do they?
Yeah, that's a really excellent point. I mean, we're fortunate enough in our neck of the woods to have a lot of kind of lung cancer, great lung cancer doctors and resources throughout our area. But that's definitely that may be that may not apply to other parts of the country or the world for that matter. So I think getting in touch with the Adaria Lung Cancer Foundation, I think, is key, because you can help steer people to where they can get the best care. I think in certain states there are maybe a distance, but seeking out opinions either via some places do phone consults. I know some of my colleagues do that, or an academic medical center in your state, to at least, if you're unsure about the next steps, to at least get another opinion. I mean, I in fact encourage patients, hey, to seek other opinions, especially if people are thinking about things and not sure, to help kind of refine what the best next step. And I think most doctors embrace that. I think everybody's open to opinion, different opinions. What I would say though is if there's a pretty set course of action and you need to be treated, we have to take that into account as well. But I think, by and large, it's always good to seek out thoughts from other doctors as well.
And our whole purpose of this program is educating patients, because we personally believe that empowered and educated patients live longer.
Absolutely.
And you see it going around the room all over and over again. How do we get that to the masses? What?
Yeah, I think in addition to the Dario Lung Cancer Foundation, I think online resources, print resources, I think numbers to call where you could talk to somebody and, hey, get some advice about the best next steps. I think, with all the information technology we have now, there has to be better ways to be able to do those things. And I think that's going to be one of the kind of future steps for medicine in general, is how could we use all the technology that we have in a thoughtful way to improve access to care for patients.
And until we get to that point, just call us, because we'll help you with questions to ask your doctor. I want to get back to what happened at ASCO. Were there any other? So one of the last things in the IO, Jonathan, that I want to touch on before we move into the next area, sort of the small cell space with Opdivo, with or without the.
Oh yeah. So.
I just want one last question for immunotherapy.
This is IO.
Okay, about the fact that people that have no markers, immunotherapy seems to be working really well.
That's a great point. So that goes to the more and more we learn. It seems that lung cancers that are more associated with smoking, that are less likely to have EGFR, ALK, RUS1 mutations, seem to have some benefit, and seem to have more benefit, and we're looking for the reasons why for that. One of the things may be related to something called mutational load, where there's more mutations in these lung cancers that have there's more of these neoantigens that then the activated immune cells are able to attack once the brakes are released by these PD-1 and PD-L1 antibodies. So that's one of the things as we learn more and more about. It seems like that's the case, and that's one of the reasons why. So it's great, that we have this treatment that is applying to more and more people, and I think that's really important. Us at UC Davis, as well as many academic centers in the country, are participating in this Stand Up to Lung Cancer Dream Team that's looking at getting tissue from a lot of patients treated with kind of just standard immunotherapy and doing advanced analysis for immune markers and for these mutational load markers to try to identify why patients benefit and why patients don't. So that's one of the big endeavors that this team is trying to do. So we're doing more and more research to try to get to the bottom of it and find out why people benefit more. We have these signals, why people don't, and what we can do in terms of combination therapies and so forth to make it work better for everybody.
And I think that kind of goes along lines with the small cell, and they're now looking at immunotherapy in small cell, at least in clinical trials, which is exciting.
Yeah.
Because we don't have a lot of options, like we do for non-small cell.
Small cell, we've been treating small cell since the late 70s to now, very similarly in terms of kind of the chemotherapy that we give. There's these platinum drugs, there's etoposide, there's irinotecan. These drugs have been around for decades, and we've been using the same ones over and over.
And not working for decades.
And initially it works great, but then it doesn't. But then oftentimes folks become refractory to these chemotherapy drugs, and they don't work in small cell. It tends to be fast growing. So there's been so many trials and so many kind of strikeouts with a whole host of drugs for small cell lung cancer. But now I think there's two new promising avenues that I think hold real promise. And one, I think, Daniel, you were talking about with the nivolumab and ipilimumab, which are two checkpoint inhibitors. The nivolumab is a PD-1 antibody, and ipilimumab is a CTLA-4 antibody. They're both checkpoint inhibitors that act a little bit differently, but both kind of release the brakes on the immune system attacking the cancer. And in combination, it seems to have more activity than just the PD-1 antibody alone in small cell lung cancer. We're still doing a randomized trial between the combination and the one drug to get a sense of how beneficial it is, but it seems to be about double the response rate of substantially shrinking the tumor. So that's one avenue, but it's still only, the response rate's only about a quarter of patients, so we're still learning why some patients respond and some patients don't. So that's one promising advance, is this nivolumab and ipilimumab combination. Even though it's not FDA approved yet, it's listed in the NCCN guidelines, which are the guidelines from major academic medical centers about one of the treatment options for small cell lung cancer. But there is a risk of the combination, and that's that there's a higher incidence of hyperactivating the immune response and not just attack the cancer, but to attack normal parts of the body as well. And sometimes these immune side effects can be pretty severe. So, and especially with small cell lung cancer, where small cell lung cancer has a propensity to have these things that we call paraneoplastic syndromes, and that's basically these immune phenomena that can happen without these immune drugs, that can cause problems similar to myasthenia gravis and other things. And so we want to be cautious in small cell too, and be vigilant for that, because we already have a higher propensity to do that, and we're adding these immunotherapy drugs that may increase that even more. Oh, and then the other one I wanted to mention was, I can't pronounce the whole name of it without looking it up, but it's called Rova-T. And this was presented at ASCO not this year, but last year. And there's, on these neuroendocrine cancers, like small cell lung cancer, that come from these neuroendocrine cells, there's high expression of this protein called DLL3. And this Rova-T drug is an antibody drug conjugate. So it's an antibody to this DLL3, where there's like this chemotherapy payload. So it specifically binds to this DLL3 protein that's on these small cell lung cancers. And when it's highly expressed, it has a high response rate, so a high chance of about 50% or so of really shrinking the lung cancer, so small cell lung cancer. So this is also being studied in clinical trials right now. So I think those are the two promising avenues for small cell lung cancer that we're looking at now. So hopefully, in a couple of years, the advances we've made for non-small cell lung cancer, we'll be making for small cell lung cancer with these drugs and other drugs that are coming through the pipeline.
Well, it's really exciting to know that there's this DLL3 there's a marker for small cell lung cancer, because we always talk about it in adeno and squame, but not anywhere else. So it's exciting. So with that, I think we'll move into the targeted therapy sort of arena. Talk a little bit about EGFR and ALK, which we've talked about quite a bit, but then talk about these NTRK, MET, and those.
So in terms of non-small cell lung cancer, we have this kind of ever-expanding pie of discovering these, what we call them, driver mutations. So these changes in the lung cancer that act as an on switch and drive the growth of the cancer. And for many of these, we have drugs that can shut that switch off and shrink the cancer. So, the big ones over the past several years have been EGFR, ALK, and ROS1, which all have FDA-approved drugs. But we're learning more and more about other changes that are acting as these drivers. So some of the ones that were presented at ASCO, one is these TRK fusions, these NTRK fusions, which are specific changes and fusions of the NTRK and its partner that lead to uncontrolled cell growth for not just lung cancer, but many other types of cancers as well. Except in many of these cancers, finding these are exceedingly rare. And so there was this trial with a drug called LOXO 101 that was presented at ASCO that was really, really interesting and very exciting. So they took not just lung cancers, but cancers of all types that had these NTRK fusions. And what they found was with this LOXO 101 drug, the chance of substantially shrinking the tumor was like 75%. So really, really high. And it lasted, the trial's still ongoing, but it seems to last a good amount of time. And so it's really exciting because, you have these rare genetic changes that occur like less than 1% of the time in multiple tumor types that we have a great new effective drug for that's really, really exciting. So even though they're rare, we now have a drug that's highly effective. So as mentioned, these small percentages add up to be a lot of patients.
And those little studies that LOXO did, they found those patients all over the world. I mean, they weren't all like hanging around New York.
I think they brought a patient from Bangladesh.
Yes, exactly.
Exactly. I think it was a young patient, and then they did really, really well, and they showed the picture.
Yeah.
I mean, it was amazing. So
because those pieces of the pie, and we didn't even know this 10 years ago or even 5 years ago, were going to mean so much. Little slices of the pie with patients with something new that had never popped up in lung cancer before, but it might be in another cancer and another cancer. And it opens up a whole new world to repurpose drugs from other cancers. But it's a global effort, not just an effort in the United States.
And that's where I think, we could use kind of information technology and the internet and kind of to try to find folks that we could, that are kind of needles in a haystack that we can match to these drugs that can be really effective. I mean, you could envision somebody coming from, another country and then, being able to even do it remotely with the proper supervision. I think that's where things are eventually headed.
Well, this was the purpose behind building the lung cancer registry, not to toot our horn again, but it's open globally where we can pick this sort of N of one information, right? There's somebody in Bangladesh that we need to talk to because there's potentially a drug here in the States, right? So
and do a shout out to find them, no different than what we did with Genomics of Young Lung.
Yeah.
We went all over the world to find these people. Yeah. And they're exciting times, but everybody's starting to think way out of the box now. Thank God, right?
Yeah,
absolutely.
Anybody, Don?
Dr. Riess, I had a question. I had a Foundation 1 report, and I had NTRK 1, and I've spoken to LACO and Dr. David Hong at MD Anderson, but my NTRK 1 didn't have fusion. And at the time, they only had one person in the trial that didn't have fusion. Have they found, that was back in the beginning of 2016, has there been any new reports on whether it works for NTRK without fusion, the LACO 101 trial?
So it didn't have a fusion partner, or it was just a point? I think there are some point mutations as well that are sensitizing. There's also an IHC, immunohistochemistry assay, that could look to see if it's overexpressed. I think that was one of the main screening things that they used too. I don't know if you've had it tested for that as well.
Was a Foundation 1. They said I had the alteration, but they just explained. I spoke with Deborah Morosini, and she said it didn't have fusion. And she said if it did, I would really respond to the LACO 101. But at the time, she just said it didn't have fusion. That's. I have the report, but I don't know.
And that was a long time ago. So that
we should probably revisit, take a closer look.
We need to revisit that. Let's get your test, and
we should talk after, because we have at UC Davis, we have a molecular tumor board with Foundation 1. So if you're interested, I think we could potentially review that, re-review that, and see what the best next steps would be.
Sounds good. I have somebody else that's interested in one of your trials too, so I got to get your card.
Okay, that's cool. Yeah.
Does anybody else have a question before we move into some of the stuff happening in EGFR? Nope. Okay. What's happening?
What about good news for ALK?
Good night. Did you hear me just say we're moving into EGFR? You're jumping.
Oh, that's
It is really exciting, though. That was probably the most.
The is very exciting.
That was the best news.
We
That was the best news.
We jumped to the end track.
You were saving the best for last, though.
I was.
Yeah.
Dang. So let's do EGFR first.
Sure. So EGFR, there were some interesting abstracts at ASCO. The three that come to mind, one was a drug called dacomitinib, and that's a drug that inhibits EGFR and HER2. It's irreversible, so it binds more tighter than erlotinib. And it was compared to a drug called gefitinib, which was similar to erlotinib. And there's several drugs that are approved for first-line treatment of EGFR mutant lung cancer. There's erlotinib, gefitinib, and afatinib. And then for T790M positive right now, there's osimertinib, which they're studying now in first-line treatment. And that'll probably be presented at the ESMO meeting in Europe this fall. So they took patients and they compared them to they randomized patients to either receive the dacomitinib or the gefitinib, and they showed that the dacomitinib, there was a several-month improvement in progression-free survival. So that's the term that we use for the cancer, for it to keep the cancer in check before, or shrink or keep it in check before it starts growing again. And it was about 14.5 months versus 9 months or so several-month improvement. We don't have the overall survival. We don't know if patients actually lived longer. That's being updated. And there was a little bit more, there was some more side effects that were from the EGFR drugs, such as rash and so forth. But it'll be interesting to see what the next steps are, because there already are, there's erlotinib, gefitinib, and afatinib. It seems comparable to the afatinib, which is also an irreversible EGFR and HER2 oral inhibitor. Some of the nuances is that only patients who did not have brain metastases because of concern about blood-brain barrier penetration of the drug were allowed on the trial. And it seems comparable to a drug called afatinib that's approved here in the U.S. So it'll be interesting to see what the next steps are for that drug. The trial was done mainly outside of the U.S. So that was one abstract. Another was an adjuvant trial. So patients with earlier stage lung cancer, this was done in Asia. They randomized patients to either receive standard chemotherapy or gefitinib, which is another EGFR inhibitor. It's approved here in the United States for first-line metastatic disease. And in that trial, the time it took for the lung cancer to come back, the EGFR mutation, was longer in the patients that received gefitinib versus the patients that received standard platinum chemotherapy. Now, our standard treatment in the United States for stage 2 and lung cancer, and these earlier stage lung cancers where adjuvant treatment is warranted, which is platinum-based chemotherapy. So they gave the gefitinib instead of the platinum-based chemotherapy, where here in our clinical trials, we're still giving the platinum-based chemotherapy in these patients and then giving the EGFR drug after. But at 3 years, I think for the gefitinib group, only about 35% were still disease-free. And then it was like about 25% or so for the chemotherapy. And those are really low numbers for earlier stage lung cancer. So one of the concerns I have about the trial is that perhaps the staging there, here we do PET scans and other things that we're able to get a good stage that it really is early stage. Perhaps some of these patients were really more of the metastatic type that just wasn't detected compared to what we see here in the US. I think the bottom line is we don't know yet in the adjuvant setting in EGFR mutant lung cancer if adding an EGFR inhibitor is better than not. So we're studying this in a clinical trial. There's been several clinical trials that have been completed, and I would say the results are inconclusive. So we have a trial at UC Davis that's sponsored by the National Cancer Institute that's open across the country called the Alchemist trial. And what that does in patients who have early stage lung cancer where systemic treatment is warranted, patients are randomized after standard treatment if they have an EGFR mutation to receive erlotinib or placebo. If they have an ALK translocation to receive crizotinib or placebo, or if they have neither to receive a PD-1 antibody versus observation. So that will hopefully, when that's complete, give us some of these, because it's a much larger trial, give us some important answers on how these drugs benefit patients in the earlier stage setting.
So I have a question. And this doesn't necessarily have anything to do with ASCO, but as I was listening to you talk, it made me think about a question I've never really known the answer to. So assume I'm a patient and I'm on Tarceva and absent T790. So let's say my next step isn't automatically Tagrisso. Can I go on an Iressa, or like why are those drugs, at least they don't seem to be
So that's a great question. So
I never know.
Patients, you know, so you're diagnosed with kind of a stage 4 non-small cell lung cancer. You're found to have an EGFR mutation. You're started on what's FDA approved is gefitinib, erlotinib, afatinib. You know, sometimes with the erlotinib, a drug called bevacizumab is added because they showed us there's some progression-free survival benefit. But these are generally, you're started on one of these 3 drugs. And then generally typically within a year or 2, it starts growing again. So what do you do? So the standard treatment is you get a biopsy because you want to see if you have this T790M mutation, which is the most common mechanism of resistance to these 3 drugs. And if the T790M mutation is positive, then osimertinib is very active. It has a very high chance of shrinking the tumor, you know, a very high chance of going for some time, once again, you know, within a year or 2 of getting good benefit from this pill drug that's tolerated very well. And the biopsy now can be more even in blood, where we're getting blood biopsies first to see if we can find it there, because if we find it there first, we don't need to do a tissue biopsy and put somebody through an invasive procedure that could have more side effects. You know, of course, if the blood is negative, we go for the tissue because the blood can sometimes be negative and you could have a false negative. Now there are other mechanisms of resistance. Sometimes when you don't find T790M, particularly, that these drugs are resistant. There's ways to signal around the EGFR. We call them bypass tracks. So there's other proteins, such as one's called MET, and there's others. There's one's called HER2, where you could signal around the EGFR, and the cancer can adapt that way. Typically, if you're started on erlotinib, for example, gefitinib wouldn't work in these situations because the resistance mechanisms are similar. You know, we do have some trials at UC Davis looking for ways to overcome these T790M negative resistance mechanisms too. One of them that we have is one with osimertinib, but also adding an EGFR antibody called necitumumab, which is approved with chemotherapy for squamous lung cancer, but because it binds EGFR, we're studying it in EGFR mutant lung cancer. So we have that trial open specifically for patients right now who are T790M negative. But we've seen some encouraging activity in the early portions of the trial that we're trying to expand it to even patients who've progressed on osimertinib adding this monoclonal antibody.
So is it fair, Jonathan, for all the folks here and online that are having a hard time following all of these options, and having all of these options is awesome, but are these not drivers? Are these not the entities that are driving your cancer? And aren't we trying to constantly outwit it?
Yeah, so I kind of, you know, that's a good point. Basically, to summarize things concisely, we try to find why it's not working and devise the best combination to target it. So if you're T790M positive, the osimertinib is really good. we're always looking to do better with other trials and so forth. If you're T790M negative, the standard is chemo, but we have trials to find, if we find certain ways on the biopsies, whether they be in blood or in tissue, to match it and target those resistance mechanisms. So
head it off
for
at the
MET,
pass.
we have a trial combining erlotinib with a MET inhibitor, and so we have these trials to try to whack it that way. But ultimately, I kind of think of it as like whack-a-mole. It's like you whack one thing and then something else pops up.
Yeah.
So where I think the future of these targeted therapies lies is taking these combinations and then eventually bringing them up front. So finding early on what these mechanisms of resistance might be and hitting them up in combination.
Hit them hard. Hit them hard. Hit them hard in the beginning.
Get-go, so they don't have a chance to develop these resistance mechanisms. And I think that's where the future lies. Because if you look at like how we treat cancers going back decades, for example, lymphoma, you know, they started out with one drug and that worked for a little bit. And then they said, well, what if we combine it with this? And they found out these ways, well, if we take drugs that have different mechanisms of action and their side effects don't overlap too much so that you can tolerate it, we come up with these combinations, and then all of a sudden they were curing patients. So what I think is going to happen is you're going to find these kind of cocktail, almost like what they do for HIV, is you find these cocktails of, okay, we're going to hit the EGFR this way, and then maybe this bypass track that can signal around it. We're going to combine that. We're going to do it in such a way that you can take all these pills and you'll tolerate it. You know, you won't have too many side effects. And then we may monitor you for resistance in the blood, and then eventually come up with, oh, there's something popping up here. Well, we'll attack it this way. I think we're years away from that, but I think that's where kind of the future
circling
is
the
headed.
wagons.
Yeah.
Right?
Go ahead, Don.
Just one question, Dr. Riess. I know at UC Davis for progression after Tagrisso, there's a mutation C797S. You guys are doing trials on that, correct?
Yes, we have trials that are opening for that. So I just want to go back and you mentioned the C797S. So one of the major mechanisms of resistance to Tagrisso, osimertinib, is acquisition of this C797S mutation, where the Tagrisso, the osimertinib, can no longer bind effectively because the EGFR receptor has changed. It's kind of similar to the T790M for erlotinib, C797S for osimertinib. So this trial I mentioned with osimertinib and necitumumab, we've submitted to the National Cancer Institute based on what we've seen when we were titrating up the dose of the combination to make sure the patients tolerated it okay. Based on what we've seen there that looked encouraging, we're expanding it to include patients where Tagrisso stopped working, including C797S. So that's under review by the National Cancer Institute, and I hope we're going to have that open in the next few months because I think we're really, you know, it's an area where we don't have great treatments at this point other than your standard treatments. So hopefully over the next month or two, we should have that open.
I just want to point out, for anybody who might be confused because we're using brand and generic names of drugs, just grab a handbook because we list them all. This is this is that. So erlotinib and Tarceva, same thing. Osimertinib, whatever, and Tagrisso are the same thing. So just for anybody who's confused, grab a handbook, page 68. Yeah?
I was wondering if anybody had looked at the difference between Tarceva patients who don't develop resistance for 5 years and 10 years, and the ones that develop resistance way sooner, to see if there are any magic differences in those who seem not to develop the resistance as quickly.
So that's a fantastic question. So Tarceva, erlotinib, you know, also called erlotinib, gefitinib, these drugs have been around now for over a decade. And initially, it took several years for them to find out it was the EGFR mutations where there was particular benefit. But there's been patients who have been on for these drugs for 5 years or more. And I know people have been looking at that. I don't know if I'm not aware that they've found anything in particular. that can differentiate the people that have done well for a long time versus not. But I know that's something that people have been looking at. But I've had, several patients who've been on for over, 5 years.
And we talk about this here all the time, these super responders, right? We have a gentleman who is on our board and has been with the foundation since day one. He's been to the living room several times. Hi, Wells, if you're watching, but he's been on Aressa since it was in trials. So he said it's Aressa, Celebrex, and Maker's Mark. That is his absolute cocktail. But it's been 16 years.
Yes, and who knows, that's not okay.
Stage 4 disease.
What a smart physician it was when he was diagnosed to leave him on Celebrex. It's an anti-inflammatory. I mean, shouldn't that be lights on to possibly look at a trial with Celebrex involved? I don't know. Common sense makes sense to me.
Yeah, it's crazy. Anyway,
not gonna hurt. Right.
Do we want to talk about ALK now?
Yes, please. Not that I like ALK more than EGFR, but we had some exciting.
We love everyone the same.
We love everyone the same, but we had some exciting responses too at ASCO.
Yeah, so I think this was one of the highlights of ASCO was this ALEC. It's called ALEC's trial. A lot of these big trials have people that come up with these very witty names, and this is the ALEC's trial. So it's alectinib, which is a next-generation ALK inhibitor. And this has been shown that when crizotinib, which is the standard treatment for these ALK lung cancers, stops working, previously, starting on alectinib can be, very effective with high rates of really shrinking the cancer and keeping it in check for some time. This trial, in addition to a Japanese trial called J-ALEX that was presented last year, looked at alectinib, bringing it to this next generation ALK inhibitor to the frontline setting, doing it right off the bat, and comparing it to crizotinib, which is an older, previous generation ALK inhibitor. And what they showed was a dramatic difference in a term that we call progression-free survival, which is essentially the time it takes from starting the treatment to finding a place where the cancer is growing again. And it showed that for the alectinib, it was over 2 years on average, whereas with the crizotinib, it was about 10 months or so. So over a doubling of the time before the cancer starts growing again. And that was really, really impressive. I mean, over 2 years. And it was generally pretty well tolerated. And a lot of it was driven by control and preventing and reduced chance of having involvement of the brain and the nervous system. So one of the big problems with ALK and also EGFR and ROS1 is we find more and more that a lot of recurrence in the brain becomes a real problem. And this drug has really good penetration into the brain, into the central nervous system. And that's one of the major reasons that drove this benefit. And so preventing that or delaying that is really something that's very, very important. And so that was really exciting. So I think that's going to become the new kind of standard for how we treat first-line ALK lung cancer. And now there's other drugs approved too. There's crizotinib, there's ceritinib, there's brigatinib, there's alectinib. Some people joke there's more ALK drugs than patients. And then you have this drug lorlatinib that's in trials, and some others that are even next generation that also seem to be effective, in particular against some of these resistance mutations where these other generation ALK inhibitors aren't as effective. So we're really making some great progress in how we treat this type of lung cancer that accounts for about 4 or 5% of all non-small cell lung cancer. So that was very exciting.
Yeah. So what about MET so we've been talking about crizotinib and some of these drugs that work with ROS and ALK.
So crizotinib is also a MET inhibitor. So crizotinib it has activity against this ALK lung cancer, very good activity, great activity ROS1. It was initially developed as an inhibitor of this other protein called MET. And there's a mutation in MET that happens in about 3 or 4% of non-small cell lung cancer, where crizotinib and these other MET inhibitors are also very, it's also very sensitive to these drugs as well. So with, once again, very high response rates in time before the cancer starts, coming back. So that's another, like I said, you add these couple percents up over, and you get to more and more patients that have more and more patients that we can bring kind of these effective pill-targeted treatments with generally manageable side effects to folks to improve, improve their quality of life and how long and how much benefit they have. So that's been really exciting.
So one of the questions, did you want to talk before I move into an online question that was emailed?
No, I just would like to address surgical patients for early lung cancer and the alarming rate of recurrence and what we should be doing with surgical patients after surgery.
Okay. So let's do, yeah, so can I do this one first?
Absolutely.
Because I think that could also be an entire living room. I got a lot to say about that. It's one of my pet peeves. So one of the questions for tonight, and this wasn't on our list, but it was emailed when she knew, when our friend in Florida knew that you were coming in. Are there any trials looking at KRAS or combination drugs for KRAS?
So that KRAS has been a tough lung cancer to find new treatments for. We've had much more success with EGFR, ALK, and ROS1, but KRAS lung cancer, that's actually the most frequent mutation that we find in non-small cell lung cancer. It's about 1/4 of all non-small cell lung cancer. So it's a huge amount of patients. And unfortunately, we haven't developed good targeted therapies for KRAS mutant lung cancer. It's actually the subject of this Stand Up to Cancer lung cancer dream team that many academic medical centers, including UC Davis, are participating in. And so in terms of clinical trials, there's been a lot of work with these drugs called MEK inhibitors. And so these MEK inhibitors, MEK is a protein that's downstream of KRAS. So KRAS gets activated and then MEK, and then other proteins along the pathway. And so there's been some looking at combining MEK inhibitors with chemotherapy. So there's been trials after your standard platinum first-line chemotherapy stops working of combining docetaxel and chemotherapy agents with MEK inhibitors. There was a trial with docetaxel and selumetinib, which is one type of MEK inhibitor, and that looked promising, but unfortunately in the larger trial, it didn't show any benefit of doing the selumetinib. There's a drug called trametinib, which is a different MEK inhibitor that has some other, that looked promising as well. And we're currently studying that in in a National Cancer Institute-sponsored trial in the Southwest Oncology Group that UC Davis is a part of, but also many other academic medical centers, of looking at docetaxel and trametinib. So that's been open at UC Davis, although it's closed right now because we're doing an analysis after we've had a couple of patients on to make sure we're seeing some signal of activity before reopening it again. But that's one trial. And then there's been thoughts of combining these MEK inhibitors with immunotherapy because there's been some combinations in there's been some promising activity seen in colorectal cancer, and we think because of these MEK inhibitors may have benefit in KRAS mutant lung cancer, combining it with immunotherapy. So we have a trial that we hope to have open in the next couple of months at UC Davis, combining pembrolizumab with trametinib, and I believe MD Anderson also has a trial that's opening soon with a similar type combination. So there are trials. Unfortunately, we haven't been as successotful with KRAS mutant lung cancer, and it's so many patients. So it's just really an area that
But there hasn't been anything yet
addressed.
using immunotherapy.
As we say, you're getting ready to open a trial.
Oh, with MEK inhibitors? No, it's not open right now.
Right,
We hope to in the next several
but there hasn't been anything yet.
No, not
So we don't know. I mean, it could be a home run.
Yeah, I mean, we'll have to. We don't know yet. So we'll have to see once we have some folks, see how they do once they start the treatment. But some of these folks, because sometimes KRAS is more associated with smoking, there are good standard treatments like, immunotherapy drugs that even though they're not specifically targeted for KRAS, may have benefit. That's even though it's not directly targeted. Some of these standard treatments like immunotherapy may have benefit.
And this is where that mutational burden probably comes into play.
Yeah. And that's one of the things we're looking at in particular, getting samples from patients treated with standard, PD-1 drugs like pembrolizumab or nivolumab and seeing what these changes are where certain patients derive good benefit and certain patients may not.
Great. Did you have a question?
I have a few questions online. There's a patient online who says she had SBRT to a lung tumor. Her doctor took her off Tarceva while she was getting radiation. However, her radiation oncologist told her, no, you should go back on treatment while you're getting radiation.
My general practice is that these EGFR drugs have generally been pretty safe with SBRT, so I generally have continued patients on their EGFR drug during SBRT. That's been our practice at UC Davis. We haven't seen any untoward effects.
Two more questions. But you can turn around. You'll get a kink in your neck. What is the role for CAR T cell therapy for lung cancer?
So I think that's still experimental. So there's been some great success in leukemias and liquid tumors, and I don't think we know yet. So I think I'm not aware of anything here on the West, but I think I'm sure it's something that'll be studied in the future. That'll be studied, but I'm not aware of any concrete benefit yet that we've seen, but it's promising.
And do KRAS patients generally do better on immunotherapy?
So that's what we're trying to learn more about. There may be some benefit more towards KRAS with standard immunotherapy. That may have to do with this mutational load and that more KRAS mutations are associated with smoking. So whether it's intrinsically due to the KRAS mutation itself or these other things that are associated with it, we're still trying to find out.
We're seeing more and more KRAS patients that don't smoke.
Yeah, it depends. There's certain KRAS mutations that are more associated with smoking and non-smoking, but we have seen some of those, and that's still more that we're trying to learn about. Do those patients do well with immunotherapy or not?
Yeah.
Interesting. So I want to ask one more question, and then we'll ask your surgical question, which is, like I said, probably an entire living room.
Exactly. Yeah.
But were there any advancements made in the diagnostics insofar as the molecular testing, whether it's for IO or targeted therapies? I know there's been a lot of controversy and confusion, particularly around IO, and no standardized testing for PD-L1 so did anything come up?
So I mean, in terms of markers that I use clinically, it's been mainly the PD-L1 expression, because if it's 50% or more, pembrolizumab for first line, and there's a proven benefit there. Tumor mutational burden now comes on some of these clinical sequencing reports, so I think that's an area that's something I also look at in terms of sometimes influencing my decision making. I think those are the main markers that are more in clinical use. In terms of, there are different antibodies that go with different drugs. So there's pembrolizumab has their antibody, nivolumab has their antibody, atezolizumab has their test. Some of them are tracked closer than others. So for example, the antibodies for the pembrolizumab and nivolumab seem decently comparable as opposed to atezolizumab. I mainly have used the pembrolizumab one just because that has an impact for first-line treatment right now. There was something published, though, recently for nivolumab that if there was a high mutational load, the nivolumab had benefit in the first line, whereas what was interesting was the frontline trial with nivolumab didn't show any benefit in patients living longer. whereas the pembrolizumab showed a tremendous benefit. So they used this tumor mutation low to try and show that there was benefit based on that with nivolumab. But that's, that was done kind of after the fact. But these are some things that people are looking at, and there's different immune signatures that the different researchers are looking at. But it's still kind of not ready for prime time just yet.
What do you think should be the standard of care for profiling, for genomic profiling, including PD-L1?
So certainly PD-L1 expression for sure, because if it's high, it's got a great treatment.
Right.
Use pembrolizumab first line.
Right.
As a single agent, it's generally well tolerated. Can give a substantial benefit over platinum-based chemotherapy. For genomic testing, the standard of care at minimum for non-small cell lung cancer that's not squamous. Or squamous lung cancer is where it's a tiny specimen or patients don't have a smoking history or much of a smoking history, is checking for EGFR, ALK, and ROS1. Those are the big three. Now, my practice has been also to do more of a broad genomic profile because, at minimum, you want to get those big three because that's going to influence your treatment right off the bat. I get it more of a broad genomic profiling because I want to know about these other smaller pieces of the pie.
Right.
For example, those MET mutations, TREC if you could find, NTREC if you could find it, and others that I could say, hey, I can match you to either an off-label drug, but that may be very effective, or a clinical trial. So my approach has been to do this broad genomic profiling. If you look at the what we call the NCCN guidelines on endometrial cancer, that's kind of something that's encouraged.
Right.
So that's been my practice, and sometimes you're surprised and you find stuff that can be really useful and helpful to patients. So,
Exactly.
So I find it critical to check that, but you should at least be getting the big three and PD-L1. But I think checking more, information is power. You want to know. It helps your decision making, even not at that moment. At least you could help for the future.
So should T790 be included in that in the event the patient presents with resistance?
So generally, when they check for EGFR mutations, that's part of it. So T790M up front without getting erlotinib or gefitinib is very rare. I mean, the Dara Foundation, you're looking in terms of those rare familial types, but they're very rare. But that's included in these EGFR tests.
And then is there, and I'm going to, you're next, Betty, but just while we're here, is there ever a time, particularly in the community setting, where you see this just becoming reflex? Like where a doctor has to just say, here's one box, look for all of it, and it's automatically there, as opposed to, we talk to patients all the time who are like, well, either why did they do EGFR first, because this is still happening, that's negative, so now we're doing ALK, that's negative, now we're doing ROS1, that's negative, Lord knows if they're ever getting PD-L1, and it's 5 months down the line, and these patients still haven't been treated.
That's a good point. Ideally, we want to get an answer within 2 weeks. That's what the guideline says.
Right.
Upfront.
Sometimes, upfront. It could be very frustrating sometimes, taking longer, but sometimes that happens for various reasons. But you at minimum want to have those big three right up, plus PD-L1 from the get-go. Not to kind of sequence them, but get them from the get-go. But like I said, I would encourage you to get the whole panel so you know up front what you're dealing with.
Exactly.
Betty, do you have a question?
I just was wondering if you wanted to speak for a minute about any improvements on the diagnostic testing that we're doing. I was talking with my doctor, and she, at one point, is wondering if I should go to CT scans as opposed to PET scans. And I'm wondering if there's been any changes in MRIs, or if you wanted to talk about any of the most current liquid biopsies.
So in terms of PET CTs or CTs, my approach has been to kind of individualize to the patient if there's something that could be more useful gained by seeing that metabolic activity in PET versus monitoring stuff with, I generally do CTs unless something gives me a reason to get a PET because I want to track the certain metabolic activity of a certain area that maybe you can help differentiate it. Is it something new that's cancer or is it not? In terms of other imaging modalities, there's a lot of research, but I'm not aware of anything that's ready for prime time just yet. In terms of liquid biopsies, I mean, that's been a tremendous advance over the past year. So, I mean, it's so much easier to draw a tube of blood than to get a biopsy, to put somebody through a procedure. I mean, it's just so much easier. And so my approach has been to draw the blood first. So if I see somebody and it's like, oh, unfortunately, things look like they're growing again, and particularly for EGFR, I want to see if there's T790M. I want to see if there's other things. Start by drawing a tube of blood, seeing if that's present. If that's present, you have a good treatment and way to go. In fact, one of the T790M tests is now FDA approved for that. I get kind of a profile of not just T790M, but I try to look at everything to see if there's other things, if T790M is negative, that we could match as part of a trial and know about that. If it's negative, though, it could be a fake negative, false negative. So, then I go for the tissue biopsy, because if you find that T790M, you want to try to find that any way you can. You've got a great drug for it. So that's been my approach, and I think it's made things so much better to be able to do that. I would just like, so the big caution was a negative test by the blood doesn't necessarily mean it's negative, and that's where you sometimes need to go the extra step and get a biopsy. Sometimes I'll draw the blood and I'll schedule the biopsy, because then we could always cancel it, and then we don't have to make up lost ground. So depending on the situation, sometimes I do that too, so we're not waiting weeks and weeks to get an answer.
One of David Gandara's, your colleague's, favorite things to talk about is at progression, after you've been on a drug and you start to progress a bit, finding out what's driving your cancer now. Mm-hmm. Could you just share with everybody online and in here that you can have another mutation down the road that is now the original driver has gotten off the bus, his words, and a new driver is on the bus, and that allows us to make new decisions.
Absolutely. With these targeted treatments, whether it be erlotinib for EGFR or crizotinib for ALK or ROS1, it's like this whack-a-mole. I'll use a different analogy, the whack-a-mole. Yeah. So, you get a test that shows an EGFR in the beginning, a certain mutation. There may be acquisition, there's acquisition of other things as time goes on when resistance develops. So you want to get, that's just one snapshot in time, but things a year or two later, maybe in addition to that mutation, maybe different, completely different. So that's where getting this other biopsy, either by the blood or tissue, could be so informative and really be a game changer in how we could bring better treatments to treat your lung cancer.
Yeah.
So I think that's absolutely critical, especially now that we got drugs that are effective that are approved by the FDA, not just clinical trials for these types of situations.
And what's driving your cancer can change.
Yeah.
Absolutely.
So,
I think the only reason I bring that up is hope. There can always be the possibility of something else down the road that's taken over that's druggable.
Absolutely.
Agreed. Joanne and Katie both have a question. You go ahead, Joanne.
Just back to the blood draw. Routinely, I have CT scans or PET scans, depending on which you decide at the time. So would blood draws be appropriate at this point to find progression? Are we that far along?
So that's a fantastic question. So, what we're taught in I'll give two perspectives. What we're taught in medical school is not to order a test that you're not going to do something about. So you're weighing that versus more information. So for example, if you're on a drug and you're getting a scan every couple of months, and for example, say erlotinib for EGFR on cancer, and things are under control, your tumor shrunk, for example, does it add anything to get a blood test? So at these time points with each scan, so hypothetically, let's just talk about it. So if things are shrinking, I mean, there's been some research that shows that if you clear out of the blood, then your chances of it, you have a better, what we say, prognosis. The time it takes for things to start growing again, maybe more than if it was still positive, for example. But it may not. So that would be prognostic. So that could provide some information. But is that information A, worth the cost, and B, would you do anything about it? You wouldn't necessarily do anything about it in that situation right now, because if you were still doing well and it was shrinking, would you really change therapy? And that's an open research question. But in terms of how we manage lung cancer now, as long as things are shrinking and people are feeling good, even if we found something a bit different, we wouldn't necessarily change anything. For example, T790M. But you could envision in the future having effective drugs and collecting blood over time and saying, hey, this new thing pops up, we could attack it with X, Y, and Z in addition to what we're doing now. That's something I think on a research basis that's very exciting, but in terms of clinical care now, we're not doing routinely. So my approach has been, I generally have not been doing routine serial blood draws with scans unless there was something that would influence my decision-making on how to best take care of somebody. So for example, if things were growing a little bit, then I would say, hey, we should check, because if we find T790M, we could talk about at some point starting osimertinib, or we have this trial where we could add a drug that may target one particular resistance mutation that may be going on in EGFR lung cancer. Things are growing a little bit, let's check for it. Otherwise, on a not research basis, my approach has been, if it ain't broke, don't fix it.
Yeah.
If you're doing well and your scans show great response, my approach is not to be going kind of looking for trouble of things that we could find. So that's generally been my approach. Does that answer your question?
I think it kind of goes along, we talked about it a little bit earlier, like that you want to stay on these drugs as long, get the most out of them that you can.
Yeah, absolutely. That's a great point. My philosophy is try to be, it's a cliche, but it's a marathon, not a sprint. We want to maximize every line of therapy as much as possible. That's generally been my approach. How much can we get out of each drug to get people the maximum benefit?
Katie.
I have a quick question. Because there's caregivers in the room and family members who have maybe parents who have been diagnosed, or uncles, aunts, I'm always curious about the other side of, like, the early prevention side. If you do have a family member that's been diagnosed, what are some of the tests or things that you can do to be in front of the disease, or be, I guess, cautious, or get tested for to be in front of it?
So I just want to make sure I understand your question. Are you talking more about if you're the caregiver for the patient you're taking care of, or are you talking about for yourself in terms of a family member?
A family member. So I'm thinking about Andi and Danielle's situation. Let's just use that. Like, what steps can they take to be in front of, knowing that Bonnie has had lung cancer and that's their mother?
Screening,
so, yeah, types of screenings and stuff. Was any of that mentioned in? Yeah, right?
So in terms of approach for screening, I mean, there is some association with family history and lung cancer. The most strongest association is with this T790M mutation,
which is a germline,
right up front, which is germline, which people pass along, not the acquired from the erlotinib, for example, but actually germline. It's very rare. But there's a family history there where the Adair Lung Cancer Foundation has an online resources to help take a look at these patients and kind of provide screening research to try to, in terms of trying to pick up these lung cancers. I mean, in terms of screening with a family history, I think, obviously the number one thing is if you smoke, to quit. The other thing would be, there is lung cancer there is lung cancer screening with that smoking history in terms of, it's been studied in clinical trials. I mean, we talked about folks that have participated in that, if they have, 30-pack year or more smoking and, age kind of 55 to 80 or so. I mean, it's a discussion to have to try to do these low-dose CT scans over, annually over 3 years to take a look and see if there's if it can detect any lung cancer, and that's shown about a 20% reduction in lung cancer mortality. But it's something that that doctors need to discuss with their patients because there's also a risk of finding these false positives that can add a lot of stress to people's lives. But that's another thing in terms of somebody having a family history of, for example, if somebody hasn't smoked and their parent has a smoking history and lung cancer, there's not necessarily any recommendation for screening or anything like that, absent of like a T790M mutation.
How far
But if
away?
you have that, if you have a family history, you can qualify for the screening program for lung cancer.
Well, certain circumstances.
But a lot of times, my mom died of lung cancer 12 years ago, and when I went to find out if there was any relation, they said, we don't have those files anymore. I mean, they throw the files out after how many years? 5 years, 7 years? Yeah. Max, maybe?
Yeah.
So,
Yeah, no, that's a tough thing. I mean, I had a situation actually where somebody who was on one of these EGFR drugs for a long time and had some changes, and then I went back to say, hey, can we go back 15 years to pick up the tissue to see if the original thing we thought was there was actually there, because it was before all this testing was going on. And they're like, oh, we tossed out the tissue like 2 weeks ago.
Right. And her sister had it too.
Yeah.
But none of the files are around.
Yeah, it's the same thing with your tissue. They
lost it.
Well, they lost it.
They didn't even know where it was.
But they didn't do any. There was no genomic testing, no nothing. So there's no way to find out. We're getting down to like the last few minutes here. So if anybody has one more question, we probably have time for it, but then we'll get into thank yous and housekeeping. Anybody?
Is there anything anybody's concerned
Tony has a
about?
question.
Bon, I thought it might be worthwhile for you to take an extract from your conversation with Pasiani on the possibility of the C word from ASCO.
Oh, okay, really quick. I had a one-on-one with Posse at a garden meeting.
Who's Posse?
Posse at Dana-Farber. And we talked about, this is the first time I've heard the cure word for lung cancer at this ASCO. And, he did talk about the fact that we have to get to chronically managed first, which is the ultimate goal, which we're on our way, right? I mean, it's looking more and more and more positive all the time. And the fact that, maybe it's possible that cancer is cancer. Maybe it's possible that regardless of where the cancer appears in the body, that down the road we'll be treating cancer by the genomic profiling, and rather than by where it is in your body. Obviously, if you have to have surgery and the tumor's in your lung, you'll have to have a thoracic surgeon and things like that. But what do you think about that?
Well, I think that's something that we're working towards.
Yeah.
Absolutely. I think there's challenges. I mean, for example, I guess I would use an example like a change that we see sometimes in lung cancer is HER2, which is a protein gets amplified, and I don't know. And HER2 amplified breast cancer. About over a decade ago, the treatment was revolutionized with a drug called trastuzumab Herceptin. And very effective in HER2 amplified breast cancer. Some effect in HER2 amplified lung cancer, but doesn't seem to be as much. Why are they different? And I think looking at these, I think but then if you look at the LUXO 101 trial, across tumor types, whether it be lung cancer or gallbladder cancer or head and neck cancer. It works extremely well. So why are there differences in some of these, and why are there not in others? And I think that's what we're just scratching the surface of.
Which leads us to data. Because every chance we have an opportunity to get information from a patient, we're thinking in these terms regarding our registry. But if you're anytime creating a clinical trial, whatever you're doing, get as much information as you can, whether you need it or not. Because I think we may find if we tested everybody, because currently we're only testing a small sampling of lung cancer patients. We're not getting the underserved. We're not getting the language, the people with language issues. We're not getting the socioeconomic issues. We're not even close to getting the data we need. We don't really know. But if we tested everybody, and the Ohio, we're participating in a clinical trial in the state of Ohio with David Carbone, and we're testing every lung cancer patient in the entire state. Going into the rural areas, going everywhere. And it's going to be very interesting to see what we find. Percentages. How many have EGFR? How many have NTRK? How many have T790? It's going to be very interesting. We're getting to the point we just have to get much more creative about how we gather this data, and faster and quicker. We're in a hurry, right, guys?
Agreed. So with that, sadly, I have to say...
We have to stop now.
Yeah. We had another question?
No.
Did we? Oh, I know. I want to give a huge thank you to Dr. Riess for coming out and talking with us tonight. We will give you another clap at the end, but first we're going to do a little bit of housekeeping. Katie, I don't know if you want to do a shout out about the events like this, especially for the folks in the room that aren't from LA or San Diego that might be interested in the San Francisco 5K.
Okay, I'm Katie Wilcox. I help with the events team here. We have some, you were saying, some LA people in the room. Where are you sitting? Oh, right here in San Diego. We put on a series of 5Ks across the country. We have one in LA, we have one in Philadelphia. But if you're interested in getting involved with our 5K series, they're pretty much in all of your backyards. So just reach out to us, let us know, we'll get you involved. You could either walk, run, volunteer in it. You can bring we have a canine caregiver component. So that's a fun event. We also have an endurance program where we buy bibs to the large marathons across the country. We just actually bought bibs to the Rock and Roll Marathon, which you can do any of them. People are thrilled about the Vegas one. We're getting a lot of questions around that. Bonnie's in. And the Tough Mudder we got bibs for, so that's our endurance program. And then we have a golf and gala. Those are more of our signature events. We have our gala coming up. Our golf event just took place. And then we also have a grassroots program, which is super cool. And that's where you basically come to us, present any fundraising idea that you have. We have heard things such as a kite flying event, to a car show, to a benefit concert. Come to us and our team will help support you to put that on. So if you're interested in any of those or even anything I didn't mention, come to me from an event standpoint, and our team is happy to help you. So thanks for being here tonight. We'll hopefully see you all out at an event someday.
Thanks, Katie. So next living room, August 15th, it's all about supportive care and managing side effects. So I know some of us, whether it's, the Tarceva rash or nausea or vomiting or fatigue or whatever it may be.
Or the diarrhea word.
Yes, the D word. We've got Dr. Francis Arena coming out from NYU to talk all about that. So we're really excited about that meeting because we are constantly, or I constantly feel like I'm scolding people for not paying attention to and or speaking with their physicians about their side effects because they're fearful that their physicians are going to take them off the drug. Quite often the side effects become worse than the disease in itself, and so we're going to have a big conversation about that.
And there are many natural ways to handle the side effects other than medication. So
yeah, we got a lot of good stuff happening there. A huge, huge thank you, obviously, to our supporters, without whom we could not make this happen. Astellas, Bristol Myers Squibb, Celgene, Genentech, Lilly, Merck, Novartis, Yahoo Employee Foundation. Thank you, thank you, thank you. We thank you, the patients thank you, from 144 countries around the world where this meeting has been viewed. A huge, huge thank you to Peninsula Television for once again coming in tonight and every month like they do, setting up these cameras, and they're here long after all of you leave, breaking them down. So huge thank you to them. If you are local, please pick it up on local Peninsula TV, Channel 26. It will be playing all month until the next one comes along.
If you can't sleep tonight, tune in.
Danielle, I think we should thank Jonathan's grandmother.
His mom. Oh, yeah.
His mom.
And his mom. Gotcha. That's funny. I want to thank the Office Bar and Grill for the food, and Miss Kimberly Shapoister over there for the gravy, the red sauce that she made tonight to go over the pasta. She made it all day. There is, I think, where is Kim? So I want to introduce a new staff member. She's here with us tonight, Kimberly Parham. She is from Tennessee, from Nashville, Tennessee. She is a registered nurse navigator, and program development person. Been working in lung cancer forever and a day, and we are so grateful to have her on board to be working with us in navigation and programs. So introduce yourself, Kim.
Monday, and she's still here, so.
Yes. Thank you all for allowing me to be part of your living room, and I look forward to getting to know all of you better over the next few days and weeks and months and years.
Thanks, Kim. And the most important people I want to thank are the patients. Thank you all for showing up here month after month, for fighting the big fight, for sharing your stories with not only the people in the room, but the people watching live and the people that would come back and watch post live. What you bring out to the lung cancer community with your stories of hope and motivation cannot be measured. So thank you all very much. Everybody, oh, and thank you, Sally, for bringing dessert. Yes. I always forget to look at you. It's like you're sitting right across from me. Sally brings dessert here every month. So thank you for bringing dessert.